and a privilege to be here today, because the Aspire project just talks to everything that I think is so important, and hopefully will become evident when we go through my slides today. Hopefully they're going to pop up. I'll introduce myself a bit more until they appear. So I'm Louise ELLS. I'm a professor of obesity at Leeds Beckeett University, and I also have the privilege of co-directing our new Obesity Institute, which is very much centred around the lived experience and addressing real-world research based on the lived experience, so very much talks to the aspects of Aspire. So it's a great privilege to come and talk to you today about obesity and inequalities, and in particular the importance of a person-centred perspective. So, hopefully this will... Oh, there we are. So I thought I'd just start off by reflecting on what health inequalities really are. So they're unavoidable, they're unfair, and they're systematic differences in health between different groups of people. And they can involve differences in health status, so life expectancy or quality of life. They can involve differences in access to care or the quality and experience of care, so patient satisfaction or experience of stigmatisation. They can involve behavioural risk factors and how they differ amongst different population groups. So examples could be poor diet, as we've spoken about earlier on, or they could be systematic differences in wider health determinants, such as employment and education. So again, really speaking to what we've spoken about today. And all of these health inequalities occur in people living with obesity. So, and sadly, following the COVID-19 pandemic, these inequalities have just widened further. So, the first inequality in obesity is really around the prevalence of obesity. We know obesity does not affect all population groups equally. We know that people from more deprived areas are more likely to be living with obesity, as are those from older age groups, certain black and minority ethnic communities, and people living with learning or physical disabilities. So when we're thinking about inequalities in obesity and thinking about adult obesity, we know that adults living with obesity are less likely to be in employment, as we've discussed earlier today. They're far more likely to suffer from discrimination and stigmatisation. They're at increased risk of hospitalisation and can suffer a reduction in life expectancy of up to 10 years. So to provide a bit of context, that's an equivalent reduction in life expectancy that you might expect to see in a lifelong smoker. So sadly, these inequalities aren't limited to adults. We know that children living with obesity also suffer from inequalities. We know that children living with obesity are more likely to suffer from stigmatisation, from bullying, from low self-esteem. We know they're less likely to be at school, and therefore that impacts on their education and their future employment chances. They're also more likely to suffer from a whole range of early onset cardiometabolic and musculoskeletal conditions, and are also at much higher risk of living with obesity as an adult, and therefore suffering from the increased risk of ill health, the premature mortality, and the inequalities we've just seen associated with adulthood and living with obesity. So just reflecting on sort of obesity inequalities in Europe. So back in 2014, the WHO published their Obesity and Inequalities report, and this really brought to light significant socio-demographic inequalities in obesity and how this gradient is unfortunately widening. They identified women and children in low socioeconomic groups to be most vulnerable, and they really brought to light this really vicious circle of obesity passing from one generation to the other, and something we really need to be addressing. They highlighted the importance of having universal policies to improve dietary intake and modifying environments to support opportunities for physical activity, but really highlighted that in order for these interventions to be effective in some of our most deprived population groups, that they might actually require some extra measures to really benefit from these policies and interventions. And it also really highlighted the cost associated with obesity, the personal cost, the cost of families, the cost to society, and the cost to our health services. amounting to billions of euros per year, and this includes that loss of productivity and sick days. So I thought it would be useful just to reflect on the association between obesity and employment, because that's obviously such a key theme for the Aspire project. And in the UK, we know it's really important. Back in 2014, we identified that 16 million days of sickness absence were reported due to living with obesity. And there was a systematic review published in 2016 that identified that individuals living with obesity missed more work through both long and short-term absences, and that people living with obesity really do experience significant discrimination in the workplace. There are a range of different studies that indicated that obesity discrimination is prevalent in the recruitment process. There's also evidence to suggest that there are pay disparities where employees living with obesity are actually receiving reduced wages, and also discrimination in the recruitment process itself and the progression and promotion opportunities. So really amounting to very strong evidence that there is weight bias and stigma directed against people with excess weight within the workplace. And there's a recent expert report consensus that stated, and I like the statement, that weight stigma, it damages health, it undermines human and social rights, and it's just absolutely unacceptable in any modern society. So we really do need to be working together to stamp out stigma and weight bias. And it was really lovely to see earlier on one of the resources that have come out of the Aspire project has been that tackling workplace weight bias, which is fantastic to see. And I just put this link up there. I get all of my students to do this implicit weight bias test, and I just think it's a really useful reflection. If you haven't tried it, I would certainly encourage you to do so. There we go. And this is why we need to consider that really implicit bias and the importance of a person-centred approach. And hopefully got the short video. She says. We might have to have it at the end.
It's coming.
Is it coming? It's worth the wait. Here we go.
So an average morning for me would be waking up in bed. After lying overnight, I have aches and pains, especially on my lower back. The thought of having to get out of bed is a struggle.
When I'm traveling with public transport to my work, I usually feel that I am judged.
At work, they don't know my name. They all know me only as the fat construction manager.
People notice you and they stare.
Society, they're going to give stigma no matter what. If you're not looking like this perfect person as they see on Instagram, we not all look like each other.
It's all day, every day, and then you wake up the next morning and it starts again.
I love to cycle.
I love swimming. My life is swimming. I teach swimming.
Painting, it's my new hobby. And I paint like a 6-year-old. I draw like a 6-year-old, but I'm having so much fun. I love it.
I'd love to see people change their judgments. To just take 1 second to pause before you speak.
People, if they were educated and understood what obesity was, perhaps maybe they wouldn't judge and shame people and they'd support them instead.
Let's actually have an aligned language, one that's mutually respectful. It is a disease. I have obesity. I'm not an obese person.
Fantastic. And that's a really powerful video, and I've had the great privilege of working with several people that took part in that video, and I just think it really brings home the message. So So, hopefully...
Electrify your metabolism back to teenage levels by eating 1/2 teaspoon.
That definitely wasn't part of it. Are my slides going to be happy yet?
Yeah, they're coming.
Brilliant. There we go. Okay. So, kind of bearing all of that in mind, and particularly thinking about some of the really outstanding work that's gone on within the Aspire project and how that's going to make such a valuable contribution to the evidence base. I was speaking to some lovely ladies at lunchtime and I was saying some of this, but I'm really concerned that the current evidence base we have is really driving inequalities, and I want to discuss some of that with you shortly. But it really does, to me, emphasise the importance of projects like Aspire and the difference that's really going to make to the evidence base. So just thinking about that evidence base. So a couple of years ago now, there was a really nice systematic review undertaken to try and determine the extent to which current evidence from long-term randomised control trials for weight management were actually generalisable and also applicable to our most underserved groups who might be living with severe obesity, so with a BMI of greater than or equal to 35. And then when you look at the trials that they included, so they found 131 trials. Sadly, only 6 of those actually reported adapting recruitment to appeal to underserved populations. Only 10% actually reported any kind of cultural adaptation. Again, only 6% gave any justification for their inclusion criteria, and over half excluded based on age or mental health reasons. Just over half of the trials reported race or ethnicity, and only a fifth looked at socioeconomic status. And then it's perhaps not surprising that when outcomes were reported for underserved groups, the most common analyses were by sex and ethnicity, with only 3% of the trials actually reporting outcomes according to socioeconomic status. Then when we look at another review that was conducted a little bit later last year, that looked at the inequalities in the uptake of and adherence and effectiveness of behavioural weight management interventions in adults. So they identified in this review 91 weight loss trials and 12 weight maintenance trials, and they assessed these trials for uptake, for intervention adherence, attrition and weight change by the Progressive Plus criteria. So this is looking at place of residence, race, ethnicity, occupation, gender, religion, education, socioeconomic status, social capital and any other discriminating factors. So of the evidence base they found, only 56 of the 103 trials actually considered inequalities. And it's perhaps not surprising that most of the studies therefore didn't identify any inequalities gradient, but where they did, positive outcomes were related to those within our more advantaged groups and societies. So sadly, this disparity in the evidence base isn't limited to adults. So a couple of years ago, I worked with some fantastic colleagues to undertake a systematic review that looked at social disparities in obesity treatment for children living with obesity. And we found that only 5 out of the 81 primary studies that we included in the review directly addressed differential effectiveness of treatment in relation to social disparities, with, as you might surprise, really being unsurprised to hear very inconsistent conclusions. So we reported that interventions really do need to be culturally and socially sensitive. They absolutely must avoid stigma. They must encourage motivation, recognise barriers and reinforce opportunities, and also be achievable within the family's own time and financial resources. As we spoke about earlier on, we are in a financial crisis with huge food insecurity. Really, really important to consider. So providing treatments that are actually attractive to families, that encourage, support and facilitate repeat attendance, and that motivate for that sustained change and are achievable within those families' resources really does require a high degree of understanding of not only the children being treated but also the wider family context. However, when we looked at the literature within this review, this understanding is rarely even attempted, let alone considered or applied. So, we're in this situation where we know that obesity is more prevalent in our more deprived groups, and yet the evidence base is supporting intervention effectiveness in our more affluent communities, and therefore unless we do something about this, this inequalities gap is going to continue to rise. And this is very clearly seen in the National Child Measurement Programme, which is our school measurement programme in England that measures children at ages 4 and 5 and then again at 10 to 11. So, bearing this in mind, we undertook a review with our colleagues at Public Health England, which is now Office of Health Improvement and Disparities, to really try and identify the barriers and facilitators to supporting families with children most at risk of developing excess weight. And we looked at the European evidence base and found that insight into how and why families with the highest risk of developing excess weight engage or indeed do not engage in weight management services remains really limited. And our conclusion was that weight management programmes, and that includes the assessment tools and the health promotion materials that might be used, really must be co-developed with children and their families to absolutely ensure that they are designed appropriately and tailored to need. So again, very much talks to the fantastic co-production that has gone on within the Aspire project. So, what does the evidence tell us? It's a bit of a sorry story, really. There are few obesity interventions that have been evaluated for their effectiveness in disadvantaged and least heard community groups. People who are more likely to be subject to inequalities tend not to participate in interventions and studies, and if they do, we know they're far more likely to drop out early. Interventions really do need to take greater account of ethnicity and social diversity. We can't assume that what works for a population average or for one group will work for everybody, and we absolutely must investigate the effect of interventions on different groups to ensure that inequalities are actually addressed and not continue to widen. So we really need to be fighting back on inequalities. There we go. And to do this, I guess the kind of first point is really to recognise that inequalities can occur at different levels, and therefore, like within the Aspire project, we need to think about a range of different approaches to address them. And I think this is really nicely summarised by Public Health Scotland. So they state that no single intervention will reduce health inequalities. It's a combination of actions, including tackling root causes, targeting resources where they are most needed, and making improvements to our living environments and our communities that will all help. So really, co-production and patient and public involvement is really critical to tackling inequalities. So I thought I'd just finish on a few slides, because this is something that I'm particularly passionate about. So I thought I'd reflect, this is a text that I wrote with colleagues a few years ago now, but I just thought I'd reflect on what co-production actually is. So it's sharing of information and decision-making between service users, providers, which when effectively applied can really improve services and enable service users to become more effective agents of change. It's increasingly being used, thankfully, to bring together academics, policymakers, practitioners and service users to provide high-quality research and high-quality services that can make a real and tangible impact to public health. Therefore, good public and patient involvement and engagement is absolutely key. So what is PPIE? It is an intrinsic part of the co-design process where members of the public or patients are actively involved either in the service co-design or the research co-production. These activities recognise that people with lived experiences contribute additional expertise and provide really novel, extremely valuable insights into what we're doing. It's really important that PPIE is research carried out with or by members of the public rather than to or about them. It really is about creating a truly person-centred approach, putting people genuinely at the heart of everything we do, and co-developing, delivering and evaluating services and research for the people that most need them. So what does it bring? Fantastic new and different perspectives. It really, really improves the quality of your research or your service. And importantly, it makes research or your service actually more relevant to the service user, and ultimately that will hopefully improve the impact of the service or research you're delivering. So, what makes good PPIE? Well, the absolute key is teamwork. As they say, teamwork makes the dream work. But underpinning this, it's really, really critical to take the time to build really good, mutually respectful relationships. Ensure appropriate funding is available, so you can pay your PPIE members for their time and ensure you pay them promptly. Good open communication with no hierarchy is absolutely critical. It doesn't matter who is involved in your group, everybody's voice is equally as important. Really important to train both researchers and your PPIE members so everyone knows what they're meant to be doing and all expectations are appropriately managed. And it's really important to evaluate our PPIE activity. This is really important. So firstly, we can celebrate when things have worked well, but most importantly, we can learn when things don't go well and absolutely make sure that they're not repeated in the future. And one thing for me is PPIE is not a tick box exercise. It's something that should be integral to every stage of your research process or your service co-development process. So the voice of lived experience, as I mentioned before, at the Obesity Institute really is at the heart of absolutely everything we do. We are very, very fortunate. We have our own public and patient involvement and engagement hub, and we've got over 250 members with that bring with them the voice of lived experience around obesity, and really are fundamental in helping us co-design and develop absolutely everything we do across our research, knowledge exchange and teaching agenda. So, as we continue to tackle obesity and tackle inequalities together, I thought I would end by providing a few insights from some of our fantastic members. Now, I'm not sure whether these are going to play, given the technicality, but just to kind of talk you through. So some of the things that have been brought to our attention that we're starting to work on are the real need around providing appropriate support for anyone that's living with obesity and suffering from emotional and disordered eating. Huge gap in support needs. There's a real gap in terms of our ability to join up care for people living with obesity and very complex needs. There's a real need to work with community champions to deliver weight management interventions within diverse ethnic communities. Weight stigma and bias, again, is frequently mentioned, and there's a real need to ensure this is addressed and to ensure that people living with obesity feel empowered to talk about weight when they wish to talk about weight, and that as health practitioners they are asking permission to discuss weight. There's also a real emerging need for far more tailored support and communication for people living with obesity and neurodiversity. And again, another area that we're working in is really trying to raise the voice and hear the needs of the LGBTQ+ community. So that is everything from me. It's been an absolute pleasure, and I look forward to talking to you afterwards.